Now, depending where you are in Australia or around the world, can I say good morning and good afternoon, everyone? For anyone outside Australia, we have daylight savings, so different states within the country are actually morning or afternoon. My name is Simon Waring. I'm your MC for today and for our very special webinar in this PCA Connect series. Personally, I bring a consumer lived experience perspective in palliative care. I was the father of a 4-year-old who had neuroblastoma. I've been involved in the paediatric project since its inception, and I'm a current board director of Palliative Care Australia. Before we begin, I would like to acknowledge the traditional custodians of the lands on which we meet and pay my respects to elders, both past and present. I extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. Now, let's say, personally, I'm currently living and working on Wurundjeri land in Victoria. Now, to set the scene, in this webinar today, we're going to be exploring a resource that has the potential to transform care for children and young people with life-limiting conditions. It's the newly launched Referral to Paediatric Palliative Care, the decision-making guideline tool. Now, we know that there is often great uncertainty around referral timing, and that can sometimes limit access to what we know is vital support. So this tool was developed to address that very challenge. This tool has helped healthcare professionals in making timely, compassionate referrals to paediatric palliative care. So throughout this session, we're going to unpack how the tool helps clinicians navigate complex decisions with clarity and how it can guide reflective thinking. And I think one thing I'll say before we start, you may also see where my face is going. We're going to have a number of panelists working online. Some will be reading text coming through on their screen. They might be checking an alternative screen. So because it's an online event, please be understanding if you see people's heads moving around. They're very involved, but just juggling more than one screen. So to set the scene, we're going to begin by looking at some of the real challenges health professionals face when they have to refer a child to paediatric palliative care. We'll then hear from Annette Vickery, who's going to walk us through the tool itself, how it was shaped, what it offers, and how it responds to the needs of both clinicians and families. From there, we're going to move into a panel discussion with our expert speakers and lived experience voices. And then we're also going to open the floor for audience Q&A. So over the next hour, if something occurs to you, jot your questions down. You can submit questions in the comments section. Don't be frightened to ask something and don't assume someone else will ask it for you. That doesn't always happen. Sometimes you'll find questions only begin to flow in about 5 minutes from the end of a webinar. So, which then makes it really challenging to give it the time it requires. So as questions come up, please feel free to put those in the chat and we'll be able to moderate those. They'll be fed through to me. So without further ado, let's meet today's panelists. And I'm just wondering if we're going to have some slides coming up. I'm going to first introduce Dr. Anthony Herbert. Anthony's the Director and Senior Medical Officer of the Paediatric Palliative Care Service at Children's Health Queensland. He's been a driving force in advancing palliative care, paediatric palliative care, and brings deep experience in supporting families through complex care journeys. Anthony was also part of the advisory group that helped shape this very tool. Next, we have Adele Fay, a member of the Referral Advisory Group and a powerful lived experience voice. Adele's perspective as a parent and advocate has helped shape this tool to reflect the real needs of families navigating paediatric care. And we also have Dr. Sundar Varapan. Sundar is a paediatric cardiologist based at Perth Children's Hospital. Sundar brings valuable insight into how timely referral can lead to better outcomes for both children and their families. He was also part of the writing group that helped create this tool. As a referring specialist, he offers a practical perspective on how this tool can support decision-making in everyday clinical practice. So please, thank you all for joining me today. And since we all have you here, I think to set the scene, can we just talk about what we think some of the common challenges health professionals face when they're deciding the right time to refer a child to palliative care? Sundar?
I think the challenges are always when is the right time, and I think that's been a lot of what our tool development has centered around, is whether we're referring often too late, and parents often feedback to us and wish that they'd been referred earlier. And so I think that's been our biggest challenge, is to get timely referrals, and that's been our main goal, I think, out of all of this, is to get people to think about referral, and how we prompt them to think about that earlier, or in a timely manner.
And Adele, I suppose with that lived experience hat, the importance of referral is going to be very clear for you.
Yeah, I guess to share a little bit of our family's journey, and now when I look at the tool, I sort of see where we sat on it. So my son was born, and within months we knew that something was not right. I think it was danced around for quite some time, and we didn't know what palliative care was. No one had ever spoken to us about palliative care. This concept of when families are ready, no one's ever going to be ready for palliative care. And we don't know what's there if no one tells us. So we had our first experience with palliative care was when we were in the ICU, and I looked up and the whole pal care team was standing at the end of the bed. And I sort of went, oh, whoa, what had happened there, if you look at the flow chart, is he had got to that unstable. So quick, let's get pal care in. And none of those conversations had happened in the background. So my immediate thought was, all right, we're here, we're not coming out. Instead, so they gave me all the stuff and I threw it all in the bin because I was very shocked by it all. Then we took a few steps back and we took a few steps forward, and out we went from ICU. And then palliative care came back into our lives, I'm going to say the way they probably should have, through conversations and collaboration, and it was an entire different experience. So we got to experience both ends. Really, I guess too early was one of the things to start with, and then it was just right after that. And from our experience, we got to live life while our son died, and our son got to live life because that came at the right time with the right people and we got the right support. So yeah, it makes a huge difference whether it's too early, too late, or and too late, there's often even worse stories. So
thank you, Adele. And Anthony, I guess listening to Adele's story, clearly there was a trigger in the system that assembled the palliative care team at the foot of Adele's bed, but there hadn't been that process to bring the family on board beforehand. Is that one of the challenges that the health system is facing?
Yeah, as you said, Simon, and reflecting on Adele's experiences, it is a conversation, it's a relationship, and introducing the palliative care service to the parents and the child needs to be done sort of in an individual and sensitive way. So I think that's really important, yeah.
And I think it's clear that if we put those stories together, it's how the timely referral can actually change the experience for the child and the family. So I think this is probably a good time we're going to invite Annette Vickery. She's the projects manager at Palliative Care Australia, who has been nursing this tool through to its launch, to share how the tool was developed, the thinking that shaped it, and we're going to go over to you, Annette.
Thanks, Simon. I'm just going to follow on from some of the insights that's just been shared. And to me, it's clear that awareness and understanding of what paediatric palliative care is the focus we need to make. In my roles at PCA over the past 5 years, meeting with, learning from, and working alongside parents and carers, I've had the privilege to hear their experiences and stories. Families trusted me with some of their most personal and vulnerable moments, and I've always felt a deep responsibility to honour and trust. I knew that listening wasn't enough. In addition to working closely with parents and carers, I've also had the privilege of partnering with dedicated and busy health professionals. They generously shared their expertise and insights, helping to shape something grounded in both clinical evidence and lived experience. Time and time again, through these meetings, I've heard two things. From families, I wish we had known about paediatric palliative care earlier. And from health professionals, there's so much uncertainty. We don't want to make things harder. These words have stayed with me, and they made it clear we needed to do better, especially when it comes to timely referrals. Luckily, this need was formally recognised back in 2022 with the launch of the Paediatric Palliative Care National Action Plan. And since then, reports from Palliative Care Australia and the Australian Institute of Health and Welfare have only added urgency, showing that by 2027, it is estimated that 41,000 children could benefit from better referral practices. And that's a huge number. It's not just a statistic, it is real children and families who deserve the right care at the right time. So when we applied for our next government grant for the Shaping the Future of Paediatric Palliative Care project, we knew we had to include a referral decision-making tool. The Department of Health, Disability and Ageing supported this inclusion. Over the next 18 months, we worked closely with health professionals and families across Australia. We completed a literature review, ran workshops, and set up advisory and writing groups. It was truly a collaborative process, grounded in strong partnerships with paediatric palliative care teams, referring specialists, and families. The development of the tool was complex. There were a lot of questions, a lot of discussions, cross-referencing, and reviewing. The tool needed to apply to all life-limiting conditions, address inequities in services across Australia, language that was common, clear and recognised across specialties and service types, and reflect the breadth and diversity of family needs. After this 18 months, we're proud to launch the decision-making guideline tool, which we're talking about today. The tool is a reflective resource designed to help clinicians explore 5 key areas: referral types, progression and management of conditions, family needs, service access, and health professional considerations. It's not a checklist. It's not a scoring system. It's a conversation starter. It's there to support thoughtful, compassionate, and timely decision-making. Each section of the tool includes questions, prompts, and takeaway points. Some of the reflective questions are the surprise question. Would you be surprised if this child died in this episode of care or within the next 2 years? Have there been changes in the child's condition indicating a decline from their baseline? Has there been an increase in unplanned hospital admissions or an increased visits with health professionals? Has there been a decline in the family or child's quality of life? Are you aware of any diverse needs and family dynamics that are unique? Does the family and child understand the diagnosis or lack of diagnosis and its implications for life expectancy and quality of life? Do your care recommendations align with the family's preferences and needs? Is the child currently receiving NDIS support? If not, what do you do? Do I feel I am prepared to support the family, considering their potential emotional responses? Do I fully understand what paediatric palliative care offers and how it can benefit the child and family? Recognising early signs of decline, understanding family dynamics and needs, and identifying available services helps clinicians build a fuller picture of what's going on. Based on the responses, this tool helps identify whether a child and family may benefit from additional support, collaborative planning, or referral to paediatric palliative care, and whether it needs to be immediate, soon, later. It also clarifies when continued monitoring is the most appropriate course, ensuring care remains responsive and aligned with the family's evolving needs. This process also highlights opportunities to strengthen existing practices and identify areas for learning and further support. Just some of the key takeaways from this tool. Paediatric palliative care can be introduced at any point in the child's journey. Paediatric palliative care can be provided alongside curative treatments. Paediatric palliative care allows for parallel planning where we hope for the best but plan for the rest. Paediatric palliative care is everyone's business. I just want to stop for a moment and share with you some words from a parent that was also on our writing group, and her name was Nadine. This tool gives so many families time to get the support they need to create beautiful memories and build a community around them as they move forward through a long, winding road. At the heart of this initiative, it's simple but important: to reduce hesitation, build confidence, and ensure referrals happen in a way that supports families. Every child deserves the best possible care at the right time, because waiting means missed opportunities. And we knew that without action, families may go without the support they need. Together, we created a resource that is truly fit for purpose, designed to support both families and clinicians in meaningful, practical ways. And I've just popped up here the QR code to download the resource. It's available in both a long version and a short version. The long version provides additional evidence, reflective points, references to go and look for additional information. And the shorter version is the checklist and the flow chart for quick review. Thank you.
Thank you very much, Annette. That gave a really good insight into the amount of the work, thought, and collaboration that's gone into shaping this resource. And clearly, when you're working with the concept of 41,000 children who could benefit from better referral, and we're talking about real world challenges. I'm going to return now to our panel to explore how this tool is or can be used in practice, hear more about the impact it can have across different clinical settings. And just to the audience listening, 2 reminders for you. Let us know if there's any, because we're an online webinar, let us know in the comments if there's any issues with microphones or hearing anyone, because we aren't going to be aware of it. And also, I mentioned questions at the beginning. When I was listening to Annette, I had so many questions popping off in my head. There's no way I could hold them all. And if you're in the same as me, then yeah, write them down, make little notes. Please pop any questions in the chat and we'll see if we can get our panel to respond to some of those. And so we will open up for audience Q&A shortly, and we would love to hear from you. So that's the starter's gun to start getting those questions ready. So with our panel, we all heard Annette give the context around how the tool had been developed. So I'm just going to go back to you, Adele. You are very generous in sharing your story this morning, and there's often a lot of uncertainty around palliative care, paediatric palliative care, what it is. Families at times may not be ready to hear or reluctant to hear about it. Could you relate that to your experience and how you think this tool might help families?
Absolutely. Again, stating that no one's ever going to be ready to be introduced to palliative care. It's just, no matter how long, it's going to hurt, it's going to sting, and it's going to be hard for the person doing it to be doing it. However, if palliative, I'll share a story of a family I was talking with last week, young girl with Rett syndrome, clear that things are not going all that well. And I said, why don't you get referred? This is another mum saying to her mum, go and ask to get referred. And she said, tell me more. And I said, you know that Zayden's my son's name. Palliative care was really our savior. And it was, we were stuck in a hospital with a very ill little boy and a very well older boy, which is a very, very big, tricky juggle. We were practicing for school camp in a hospital room. We were having Christmas in ICU, getting moved down the night before. Luckily, the palliative care team came as Santa, thank you. But this world that once they got involved, and I know they probably won't want me telling everyone the things they can make happen, but they can make things happen that no one else can. I think they have a certain comfort around dying children that it's like, you know what, let's take a risk. Let's see if we can do this. Let's see if we can help this child live. So to give you a really solid example, I remember sitting there one day and I was talking to the palliative care nurses and I said, we've got soccer, but we need to get his driver changed. So Zayden was on a drive infused with morphine and Madaz. So pretty hardcore stuff that we're carrying around in his pocket. And they said, go to soccer, we'll meet you there. So off we went with his driver. We got to watch soccer. He got to sit in the sunshine. Without them, we wouldn't have moved from that ICU room because everyone else can be too scared to let a dying child live. Had I had known that, had I had known what was available to me with up here, we're lucky enough to have Hummingbird House, which was our other lifeline. Had I have known that I would have someone to call 24 hours a day and say, help, what can I do? the other thing is, had I known I would have people to come in without that face that we get from everybody. Our doctors, they loved and they cared so deeply that in the end they would walk in the room and have tears in their eyes because his pain was too much for anyone to handle. And the palliative care team, as we know as parents, you get immune to this kind of stuff and you get a bit of a hard shell, and they were able to walk in and have matter-of-fact conversations with us that at the time was really appreciated. So I guess what I'm saying is my friends who are now all palliative parents, I guess, when they start to hear this stuff, they go, oh, that could help us. That was great. The other night we had to go to ED because of this, and that could have been a phone call. So palliative care can help people live life. So they're 24 hours, unfortunately for them, but very fortunate for us. And if we reframe it into, so for a child like mine who lived to 4.5 years of age, he was dying for 3 years of that, but he was living life while dying. And the alternative would not have been the same without palliative care. So, and in saying that, we were dying and we were seeking treatment. We were getting flown for brain surgery to Sydney. So it's not, that's another thing I didn't understand. If we let palliative care in, does that mean we can't try experimental brain surgery? And you can. And all of that happened alongside each other and was actually made smoother by palliative care. So I think if everyone actually understood that the dying part of palliative care is the tiniest little part at the end, and the living part is what they're there for.
Which also echoes Annette's comment that often paediatric palliative can sit alongside a curative treatment.
Absolutely, yeah. The whole way with us, we never gave up, ever.
Yeah. So it sounds like there's uncertainty on the family side because of knowledge, and then there's clearly uncertainty on the clinical side. And so, Sundar, as a cardiologist, if we reflect on that, how have you worked as a specialist with a palliative care team to care for a child and their family?
Thanks, Simon. I'll try and speak louder, I think, just because people are having trouble listening. I think listening to Adele really reinforced one of the patients that we worked with when she talked about, living while you're dying. And for us, there's a lot of heart conditions where treatment is quite limited. And I'm reminded of this patient we looked after with cardiomyopathy, where the heart's failing, and the only real effective treatment is a heart transplant. And obviously, there's a wait list, and not everyone makes it on to get a heart before they die of heart failure. And so it was very important that, we talked about that. And again, I think we've heard it a few times in this webinar. It's about parallel planning. Just because you involve palliative care doesn't necessarily mean you're not seeking curative intent. So he was on heart failure therapy. He was waitlisted for a transplant with Melbourne, which is our service. But during that time, we wanted him to live. So we got Pal Care involved while he was waiting. And just like every Pal Care team across the country, I think ours are fantastic. It was really important to the family. Again, they had a child who was well and healthy, and they had this sick child, and so they wanted to build memories for the family while they were waiting for the transplant. And I think one of the really important things for them was to go to our zoo. So we have a zoo in the city, and that was a really important thing because he had spoken about going to the zoo a lot. And so Pal Care make magic happen, and they brought the whole family out, and he enjoyed that time at the zoo. And for the family, that was the best memory making they had, and they really spoke about it. Unfortunately, over the course of the 18 months, he did progress to his condition deteriorated. He didn't receive a transplant, and he went on and died. And when they found the palliative care involvement and the fact they facilitated a lot of the memory making, not just the trip to the zoo, really worthwhile. They really reflected on it, and so it's very useful for the family. And I'm really glad we involved Pal Care, and the family didn't feel like we'd given up on them. which I think as a referring specialist is my biggest challenge, is when we bring that conversation and we let the family know, we're not giving up on your child necessarily per se. We're still pursuing treatment, but we understand the limitation of that treatment. And I think the other patient that I really reminded of is another young boy who really, we didn't quite know what was going on. He was quite unwell. He was in hospital. He was in ICU, and things weren't really going well. And we didn't really understand what was happening, what was the cause of it. And he was about 6 months, and we thought, this is all not going the way we wanted, and we thought it would be helpful to get PALCare involved. Again, parallel planning while we were actively getting treatment as well for his various complexities. And he actually improved and did really well. And just recently, I got a letter about him potentially graduating from PALCare, which I know is an unusual thing, but he was doing well and he's actually come around the other side. So I said, yes, from my point of view, he should graduate. So our PALCare team graduated him, and they said, we'll see how things go. There's a lot of uncertainty in medicine that I think people don't appreciate as well. And sometimes having people support symptoms, and the benefits, again, as Adele said, is 24/7. We're a 24-hour service, but we don't do the medication management, the going out to the families and helping with things like NG tubes and drivers. And so a lot of resources are brought on board by our PALCare team to help us, so parents don't have to keep driving to the ED to put in an NG that's fallen out, or various other things. And in Perth, which is one of the biggest states, that's really a benefit for families as well, to stay home for as long as possible, and that is important for most families. Unfortunately, no one likes hospitals, so they want to stay home as long as possible, as long as we can make it for them. So I think it's been really useful for me personally. And I think a biggest thing for me is this parallel planning. I think when I talk to patients, and I've said this when we're doing our writing group, I almost feel like PALCare needs a rename as assisted care or some other form where, as Adele says, the dying is just the small part of the wonderful service they provide. And so most people are aware of PALCare as just, the end, whereas actually there's a big range of services they provide.
Thanks, Sundar. And actually, I'd probably agree. I know there's I don't think we can rebrand it in half an hour, but that's been a common question that's thrown up. Anthony, listening to Adele and Sundar, you've, as a paediatric palliative care paediatrician, you've sort of sat very much in that space where you're working with referring health professionals. What are your learnings from that process?
Thanks, Simon. I think we're always learning, like we're lifelong learners. So the referring doctor can teach us a lot about the child's particular condition, which can be a rare condition, and then I guess they're coming to the PALCare service for various practical and emotional supports, symptom management, providing care in the home, streamlining care in hospital when it occurs, linking in with the children's hospice and partnering with the children's hospice when there is one available. So it is very much a mutual learning process. And the tool does say that some referrals, the needs of the family are immediate, and then there's a time frame of soon, and then there's sort of maybe later or anticipating. So my experience is when it's an immediate need, usually the pediatrician or the pediatric specialist will give me a call and just explain the case to me or my colleagues and just let us know why they're referring, and maybe to get some initial feedback, which can actually allow sort of management to continue while the family are waiting to meet the team. And then maybe if it's one of those referrals that's not urgent, there might be quite a detailed letter that comes. And so I always find it's very important to honour that information from the referring clinician, either listening to the story that they're presenting to me, or alternatively reading their referral letter in detail. And then when we meet the family, it's very much trying to do it in a way that puts them at ease and helps them feel comfortable. As Adele said, this is never going to be easy meeting palliative care, but acknowledging that. And some families will want to sort of tell the story themselves to you. Other families are maybe a little bit tired from retelling the story over and over. So you sort of have to gauge it to that particular family, and sort of use the information that's been given to you through the referral process, as well as sort of give full opportunity to the family to really tell us about their child, and questions like, tell us more about your child. What does your son or daughter enjoy doing? What are you hoping for? What are you worried about? So that those things all sort of build into the consultation. And it's really important to maintain that contact with the referring paediatrician and the nurses and allied health staff that are caring for that patient, so that, because we're coming in as an extra layer of support, we're not coming in taking over care. And so the families are often reassured that the paediatrician that's often been there since diagnosis is staying with them, or the oncologist and the palliative care service are there as an extra layer of support, not sort of replacing the existing care that's already in place.
Thanks, Anthony. And it's I'm already seeing some questions coming through from the audience, and one is very much, what do you think the barriers are to early referrals? Sundar's just gone offline, so I'm going to throw that back to you, Anthony. What do you think some of the barriers that stop clinicians making these early referrals?
Yeah, and we did sort of cover that a little bit earlier, where maybe we're a little bit worried or concerned that we might distress the family by raising this, but then we know families want us to tell the truth and do it in an honest way, and we can sort of communicate in a way that sort of also appreciates the uncertainty that we're dealing with. So, for example, using that parallel process, like I'm wondering if the Paediatric Palliative Care Service may be able to support you in this way. It might be a particular symptom or something related to home-based care, and just gauging the family's interest in that and explaining it. So sort of that's one option, and that's sort of some practical sort of support, whether it's around sort of navigating the NDIS or what I prefer to call specialist short break care, but it's probably more well known as respite. So those really practical supports, and sort of trying to optimize the care of the child. So you're sort of going in sort of hoping for the best, but just being prepared for the other or the rest. So that's sort of parallel planning. So we're not taking the hope away from the family. And if you stop and think about it, I heard someone say recently, it's impossible to take hope away from a family because the family hold that themselves for their child and their family. So you're working with that hope and sort of supporting it and fostering it, but also bringing in reality, and discussing the reality and the truth, but in a very kind way, in a way that the family find meaningful.
So that it sounds as though that fear of taking away hope or walking on eggshells around the family, that exists within the health professions who may not have a broad knowledge of paediatric palliative care. So Sundar, we missed you. Your connection just went and came back. And so we had a question. Interesting, it was a question posed to you in the chat about, which Anthony was answering, what do you think may be some of the barriers to early referral? So as a specialist, what have you found?
A lot of it is the clinicians. I feel like we feel the parents are not ready. we feel like, oh, they think we're giving up on them, or us not being aware of all of the services Palcare can provide, and add to that patient's care. So, a lot of us, we wouldn't refer if they were in ICU, for example, because we think, well, they're here, what's Palcare going to do? We'll wait till they go home, and then, or they get worse, and unfortunately, as Adele experienced it, then we make an immediate referral to Palcare. So I think it's just being aware of the friendly face at the end of the telephone, and just calling Anthony and saying, hey, look, I've got this patient. I don't know where they're going to end up, but I'm worried that things may not turn out as well as we all hope. And what can we do? What can you add? And I think a lot of the barriers are actually health professionals rather than parents, we find. And I think that's what Adele said too. She has to encourage family members to ask their treating doctors, because we want to do the best for our patients, and we often feel involving Palcare is giving up. So I think that's the biggest barrier.
And Adele, you have referred to this and made mention of that, and as Annette said, there is hesitancy and reticency. People are reticent to refer because sometimes, I might upset the family, might tread on their toes. There's a lot, because clearly it's the families are often emotionally, if not physically, exhausted by the time we get to this referral. But at the same time, from your experience, what are the family actually needing? Because what is that hesitancy getting in the way of?
I think, just finishing off there, what I see as a parent looking in what the barrier is doctors are human too. And the relationships that you build with that treating team. So, I mean, our pediatrician was with us since our son was a month old. And the relationship that we had, he took on everything because he said, I can do this, I can look after him. And he had me as a parent coming in and going, look, he turned his head. And look, he's doing this. So how's he turn around to me and say, Adele, actually.
Oh, Adele,
you guys just saw it as my finger in my excitement. So this is the type of parent that he's getting from me. And I'm saying, do you think he's going to get better? And I believe in rebellious hope. And every time I saw him, and he started to get caught up in my rebellious hope. And it was a good thing, because he would demand that someone that walked in the room went and introduced themselves to my son first. And it changed the way that his care was. But then for that person to then go, actually, this is not working out in the way that we wanted, especially in a child like mine, where I know that palliative care, Anthony referred to it as Aiden's dance with life. He wasn't fighting, he was dancing, and he was amazing, and then he was sick, and then he was amazing. So it can also be that they're going, wow, he's better today. We don't need them. But what are we missing out on? We're missing out. I'm going to put this back to something really, really practical. 138 days in hospital, and I didn't know that I could get a meal voucher to get fed. We're missing out on that.
But it's those practical things make a massive difference.
Well, it's a tiny difference, right? But it's not. When you have no income, you're caring for a child, and that could have been my lunches and dinners for 138 days, but nobody told me. Because often parents like me, especially parents that can advocate, we won't say, hey, I need help. We need someone to come and say to us, this is what we have available. What could help you? And that's when I put up my hand and said, my car's been in that car park for 138 days. I'm really scared of how much that's going to cost. And a magic wand is waved and there's no fee for the car park. And those types of things, alongside of this grief and this pain of your child, these families are thinking, how am I going to feed myself today? So those types of things. What would I have missed out on? I would have missed out on every single parent-teacher interview for my eldest son, because I couldn't go because I was looking after him on my own. So what would happen is we would try and get a little short stay at Hummingbird House arranged by Palliative Care so that I could do those things. I would have missed out on birthdays. Instead, the whole palliative care team, the pediatrics and neurologists, my sons were born 1 day apart. So they wanted to get us out on my son's birthday so that we could go. So we had a few hiccups on the way, and then we got to Hummingbird House at 7 o'clock, and there was an enormous birthday cake there waiting for my eldest son. So these are the little things that become really big things for our families, because my son remembers having birthdays that weren't taken away by his little brother. He remembers the Christmas. He just raves about it. The Christmas in hospital was amazing. That is how his journey continued, because after his little brother died, we all have to keep on living. And if our family's that broken that we can't move on, or if there is that much anger towards the sibling that has taken the whole life, other things of when I called after, so we'll talk about the death, what would have happened in the death. I would not have called someone I didn't know so intimately at 3 o'clock in the morning to say, we don't want to give him any more stuff. He's done. His port's fallen out. We're not coming back to the hospital. And to feel safe to be met with someone to say, what do you need from us? Do you want us to come to you? You're not coming? I said, we're not going to the hospital. I'm not going in another ambulance ever. And they said, okay, would you like to stay at home or would you like to go to Hummingbird House? And to know that we got in the car and were met there and were looked after. If that was a stranger that I'd only just met, I wouldn't have done that.
And those examples, Adele, it's a meal voucher is not a small thing. The ability to ring someone at 3 a.m. is not a small thing, but that speaks to the time and the education and that's been allowed, which also speaks to the referral in good time. And as we know, paediatric palliative care supports the whole family. So often siblings do become the orphan. And that's often misunderstood or not understood by a lot of people. I think, Anthony, I was listening to everything that Adele was saying, and then in your role, there will also be times where we've spoken about uncertainty on the clinical side, but I'm presuming there are times where the referrer, that you might be dealing with a specialist who is ready to refer to paediatric palliative care, but the family isn't. How do we actually work with that?
Yeah, very good questions, Simon. I think we're talking about sort of just right time referrals, so not too early, not too late, and that does depend on a combination of the child and the family and their preferences and goals, the health professionals and the palliative care service, as well as the child's condition themselves. If I guess the referring doctor can still have a discussion with the specialist paediatric palliative care service or the children's hospice, and if the family sort of are not able to meet the palliative care service, then I guess the services like ours can still provide indirect support to that paediatrician or that cardiologist or that oncologist around sort of pain management or just support in making really difficult decisions. So that's one way that we've sometimes sort of dealt with that, I guess, or managed that just by providing indirect support to paediatrician or the nursing staff that are caring for that child and their family. And because paediatricians and paediatric staff, nurses, allied health staff, chaplains are very good at that child and family-centered care. So they're probably already doing that, but we're just sort of supporting them indirectly with pain and symptom management or other sort of supports that might be needed. And maybe through that process, the family may become a little bit more comfortable with what the palliative care service is doing, and may be willing to meet them at some stage. And it is really around about a relationship and building a relationship, and then sort of and that ongoing relationship and conversation, and sort of trying to support the family as best we can, both practically and emotionally.
Thanks, Anthony. And one thing I want to circle back to is Annette, when she was describing the tool, she was running through some of the prompts and questions that the tool offers. And it's interesting in this space because often we know, I smile when I say it, we know that clinicians love nothing better than a checklist, but deliberately this tool is not being presented as a hard checklist. It is more of a reflective resource. Sundar, Anthony, can you talk a little bit how the importance of why that is?
I think it's important because it gives you a framework to think about decisions, and also I think it's important because you can think about where the patient is in their journey and see. And again, we've spoken a lot about timely referral, and sometimes you think, especially as a referring doctor, you think you are supporting the family, and then you look at the tool and you think, actually, I'm not sure I am. Like, there are services, they're not well supported, and they can't call us at 3 a.m. and ask us to come out and help because their children are breathless, because we don't have that capability in our service and we have to make them come to ED. So I think the tool is really good to go back, and I think Annette said it more about reflective questions to focus on. We all want to do the best thing, but are we? And I think that's been the most important takeaway for me in that tool, is to make sure that we are doing the best. I was just going to circle back about what do you do if the family's not ready and you don't see the light at the end of the tunnel. We often have that because we have a huge range of congenital heart disease that we know the outcome's not going to be perfect, but as Anthony says, you hold on to hope, and hope. We always introduce it, I think, and then I usually talk about all the support, additional support that PalCare can offer, in addition to curative and surgical and medical treatment that we offer. And I leave it at that. And then I revisit because often it comes as a shock to the parents. They're exposed to this, what was usually a very well healthy child with this, condition. And so I leave it with them, and then I revisit once the family have had time to settle and process, and just revisit them again. And often offer just a chat with the PalCare team to see, how they can help in the patient's journey. And I think that's useful too. Obviously, if the parents are ready, then we leave it at that. But I think it's important to go back and revisit once the family have had time to process the shock.
Thanks, Sundar. I've got one question in the chat, which it looks like it was written by a Paediatric Palliative Care paediatrician. I'll read it out, and then it'll almost demand a silver bullet from each of you. How do we encourage the uptake of this tool to encourage the timeliness of referrals to paediatric palliative care teams? And this is the bit, rather than Friday afternoon as a child is going home. Anthony, any silver bullet thoughts on that?
Well, I think this webinar is a starting process for that. And yes. I think the way that the project has engaged not only those working in paediatric palliative care, but a number of referring specialties, as well as parents and consumers. I have jokingly suggested maybe we could put the diagram on a mouse pad, and so so there's
Thumbs up.
so that's kind of the job that lays ahead. But the tool is reflective, and I think as we as the referrers refer a case to a palliative care service, and as the palliative care service receive and care for those children and families, we reflect on each of those cases and learn, what went really well, what could have been done a little bit differently. And so I think that sort of reflective aspect to this tool will be quite powerful moving forward.
I think just increased awareness. I think getting people to realize that it's out there. And I like the mouse pad idea. I think leaving it everywhere is a great idea. But I think just increased awareness of what services are available is the key.
I think from me, I think I walked into ED last year with my now little baby girl, and one of the registrars who was in the palliative care team burst into tears when she saw us, and she said, "Zayden taught us how to live while and he changed the way that we think." And I think if the hospital or the doctors have a chance, find consumers that can come and talk to you and share their journeys and share it within the hospital. And because if it's not a journey that you haven't walked before, it's not something we can expect to know. And even it could be sharing within the hospital with consumers that have done this before. And we can vouch for how amazing palliative care is. It's a place no one ever wants to know about, but I tell you, once you've got it, you're so grateful that you knew about it.
Thanks. And unfortunately, we're reaching the end of our webinar. We've hit, 127, 128, and I feel we could keep this conversation going. I think from the audience, I'd like to thank all of our panelists for taking their time and the generosity of sharing their experience and expertise today. I'd like to thank everyone who's joined us. Please raise awareness. We do hope this session has given you a deeper understanding of the importance of timely referral, and that this new tool, as Anthony was sort of saying, it can help support you in making confident, compassionate decisions, and it becomes an education tool in its own right. So we would encourage you, if you haven't already, to explore the tool via the Paediatric Palliative Care website and consider how it might support your practice. Now, just to let you know, after the webinar, you will receive an email from Palliative Care Australia with a link to this recording. We'll have a link to the tool and any other relevant links, so keep an eye out in your inbox. And lastly, let's continue working together to ensure children, young people and their families receive the care they need when it matters most. So thank you again, everyone. Thank you to the audience. Thank you, Sundar, Anthony and Adele. And thank you, Annette. And thank you, everyone, for joining us, and all the backroom boffins who helped this tick along smoothly for the last hour. Goodbye from everybody.
Thank you.
Thanks, everyone. Cheers.